When you look at the 2013 pain, agitation, delirium guidelines, and I was one of the members of this group, some of the most important guidelines are actually non-pharmacologic. So I think some of the weakest evidence we have for what we do in the ICU is with sedatives, the choices of analgesics, and drug therapy. And some of the most important things are really the assessment piece. I think a critical thing that needs to happen is it's hard in patients that can't self-report pain. Pain is often missed. Every critically ill patient has pain. So if a patient's a little bit sedated or they're intubated and they can't communicate that they're in pain, it's very, very important to use nonverbal pain scales. So that's the CPOD or the BPS. Those are very well validated tools. Many institutions have implemented those in the ICU. So I would encourage pharmacists to have a big role to help interpret and use those things, because pain drives a lot of things. Pain, if patients are in pain and it's missed, patients, rather than getting fentanyl or maybe Dilaudid, will actually be treated with a sedative. So you're actually treating pain with a sedative because the patient might be agitated, when in fact what the patient really needs is an opioid or another drug with analgesic properties. In fact, the use of these instruments is shown to dramatically decrease the amount of sedative use. So it boosts opioids, decreases sedatives. So that's, I think, one big thing in the guidelines. I think the importance of, again, evaluating delirium with using regular sedation assessment, and if the patient's more deeply sedated, waking the patient up before that.